So far, what we heard from our colleagues, and yet we're all agreeing to the points that we are listening to is, number one is we all agree that surgery and resection and RFA and transplant are curative intents. Sadly, they are amenable only to a certain number of patients, maybe about 15% or so. As Riyad mentioned, there's a migration where our patients might present or migrate to a more advanced disease, being either local, where the local therapies will come into play, or of course systemic therapy a little bit later on. As Amit mentioned to us in the end, also, at the moment, there is no role yet proven for adjuvant therapy. This is a discussion that's been ongoing for a long while with the retinoics, with the yttrium, the iodine-131, then with the sorafenib, and now with the checkpoint inhibitors. So far, everything has been negative. However, the current intent is to see if the current trials that looking at the checkpoint inhibitors, like the Checkmate 9DX trial, might lead us to a suggestion that the checkpoint inhibitors might be of value in regard to adjuvant therapy. We don't know that yet, but at least this is, to sum up really where we are in curative therapy. But I would like to go ahead back to the discussion that Riyad already kindly started, and in regard to embolization. Now, a patient will come and say embolization, and frankly, even sometimes physician, like, how do you choose radioembolization, chemoembolization, bland embolization? There's an endless number. Tell us a little bit, like, who's who here.
So that's fair. There's no doubt that the standard of care for those patients that are candidates for embolization is chemoembolization. That's what we have level 1 evidence on, and that's what sort of most people follow, particularly in the West and particularly in Asia. The reality is there are patients that will want to be individualized to something else, and there is a lot of center expertise. For example, Memorial Sloan Kettering practices bland embolization with similar outcomes. At Northwestern, we practice a lot of yttrium radioembolization, also with similar outcomes. And I think the evolution of embolotherapy, while demonstrating a survival difference is going to be difficult, things like quality of life and toxicity and cost, et cetera, are things that are going to be important as we develop new guidelines. But you're right. The reality is patients come, and there are various types of embolotherapy. There are advantages and disadvantages to all of them. Center expertise is very important, just like it is for resection or for transplantation. And that will often dictate what the patients get. But in terms of what the data shows, the survival is effectively the same in all of them when you observe the outcomes. And there are some differences in tumor response and side effect profile and quality of life that I think we really need to study.
Fair. I totally agree. And so, Peter, along that line, who in your mindset will be the right patient applicable for yttrium embolization?
Yttrium is a complex story, and it's basically the problem of the experience of the center, exactly such like Riyad was summing. The trials which have been trying to compare yttrium with sorafenib, we now have 3 phase 3 trials. They all prove to be negative. But it is quite clear that if you, for example, would compare a surgical approach with a truck, all these influences with respect to operator experience and center experience, they will have an impact, and it basically means that it's not the same whether you receive it in Chicago or at some other place. And that is really contributing to the difficulty. In my personal experience, I think yttrium plays a role, but the group of patients is undefined, and in guidelines, we do not have the evidence to point out clearly what can be done. We have the situation that yttrium is applied in intermediate stage as an alternative to TACE, and Riyad has very nicely shown that there's better local tumor control, but a similar outcome. What does that mean? Difficult to assess, and I would again follow center experience. If you are very good at it, it's perfect for the patient. And in an advanced stage, an individual decision where we cannot give guidance, and it's coming again back to center experience.
Fair enough, and I think this is an important point. But Amit, so the question comes in here, and I would like to hear your thoughts or critiques in regard to how these studies that Peter referred to. So as we know, and this is not necessarily that we all agree, and maybe it has some nuances in regard to the BCLC staging, but as we kind of gather, give and take, that the BCLC-B patients are the ones that we're going to apply some local therapy, being as it was presented by both Riyad and Peter, is like, chemoembolization bland or radioembolization per se. On the other hand, the comparative efforts, for example, in the SARA study, was the radioembolization versus sorafenib. And in other words, you're comparing like a BCLC-B kind of therapy to BCLC-C, and i.e. as if like, there's some kind of like push the Bs to extend more into the Cs or vice versa. Is this the right approach, or what are your thoughts on that?
Yeah, I think, the BCLC puts people nicely into these buckets, BCLC-B, BCLC-C, but I mean, at the end of the day, it's more so a spectrum. And the question is, as we try to figure out where radioembolization fits, does it fit into a one bucket cleanly, or can it be extended to several of these buckets? And I think Sarah and Survanib started to, and I don't think it's the end of this discussion, but started to evaluate this. We all know that there are some limitations to this. I mean, so for example, both the studies use serospheres, not theraspheres, and so you can imagine that potentially with more boosting and higher radiation doses within the tumor, you may have differential responses, and the results of the trials may be different. I think what we can say is, based on these data, currently we have no data to say that Y90 actually does better than sorafenib. And so systemic therapy remains, at least in my mind, the current standard of care for BCLC patients, including those with portal vein involvement. However, we also do have some non-randomized data that shows that you can have good results with theraspheres in selected patients. And so that's why I don't think that this is the end of the story. I think we're only halfway through, but I think that really what we need is continued trials to really figure out where theraspheres or where Y90 fits into this whole story.